It's 2 minutes past 8, so without if you're quite happy, I will start now. So good evening, everybody, and thank you for joining us for our 19th webinar from the East Sussex Eye Group. I never thought we'd get this far, so thank you very much for your support. This webinar is being recorded and will be available to watch on our YouTube channel, as long as the previous webinars have done as well, if you want to watch those. There is one CET point available for tonight's lecture, and that's if you're watching it live from the link when you're registered. The CET point is available for optometrists and dispensing opticians. The webinar will last for about an hour as usual, and there'll be time at the end for questions. So at the bottom of your screen, there is a Q&A box. So if you have any questions, please post your questions in the box. And at the end of the lecture, I will then post them to our speaker. So for tonight, I would like to welcome our speaker, Mr Pantelis Ioannidis. After finishing his medical school training in Italy, he then went to complete his ophthalmic surgical training in Athens, working at the University Paediatric Hospital and then at the prestigious Red Cross Hospital of Athens. He moved to Wales to join the ophthalmology department at the Singleton Hospital in Swansea in 2011 and was there for 2 years before becoming part of the ophthalmology team at the East Sussex Healthcare Trust in 2013. In order to expand his anterior segment experience, he completed a 2-year of an honorary clinical attachment at the corneoplastic unit at the Queen Victoria Hospital in East Grinstead, alongside his job at East Sussex. Currently, he is a consultant ophthalmic surgeon with a specialist interest in anterior segment conditions and medical retina, as well as being the ophthalmology clinical governance lead at East Sussex Healthcare NHS. So for tonight's webinar on anterior eye injuries and trauma, I'd like to welcome Mr Pantelis Ioannidis. I'll hand over to you now. Thank you very much.
Thank you very much, Ian, for your spontaneous introduction. And I'd like to thank as well Mr Gashani and Mr Qureshi, who have invited me to be part of this very nice, interesting group. Today, I'm going to focus this webinar on the anterior segment injuries and trauma. And I'm going to go into details on some things, and I'm going to skip some other things that might not be interesting to you. So I would like to know, or if you have some spare some times regarding your feedback, what would you like to know, or what were the things that probably were not that interesting? So in order to try to improve this for me and for all of us who do this webinars. And then let's see. Let's start. I'm starting from the first one, the last one. Should be the first one. All right. So we're going to talk about anterior eye injury and trauma. The eye injuries are serious ocular incidents that constitute around 10 to 15% of all ophthalmic diseases, with a worldwide incidence of more than 55 million a year. So we're talking about lots of patients and lots of injuries. There has been many aspects on how to classify these injuries, and there's the Birmingham eye trauma terminology, which was created in 1996 to provide a simple and clear definition of ocular injuries. This is taken from the American Academy of Ophthalmology. This is a very nice GIF file that explains and shows when we have an open globe rupture, laceration, penetrating injury, perforating intraocular foreign body, or a closed injury. Let me do this as well. That might help a little bit later on. I'm going to talk about a little bit the zones of injury. When we have an injury, when we have an open globe injury, we have the zone 1, which involves the cornea and the limbus. Then we have a second zone, zone 2, which involves the limbus to 5 millimeters posterior into the sclera. And then zone 3, posterior to 5 millimeters from the limbus. So when we have an open globe injury, it's easier to classify, or between us, we have an injury in zone 1, zone 2, or 3. When we have closed globe injuries, so in zone 1, we have external anterior segment, including conjunctiva, sclera, and cornea. In zone 2, we have internal anterior segment, including lens, zonules, and pars applicata. In zone 3, we have posterior segment, including vitreous, retina, optic nerve, choroid, and ciliary body. We're going to continue a little bit with the classification, and then we're going to go to examples. We have mechanical injuries. We have practically extraocular foreign bodies, a blunt injury, contusions, penetrating and perforating injuries, and then we got perforating injuries with retained intraocular foreign body. And then we have chemical injuries with acid burns and alkali burns. First of all, it's very important when you got a patient with a trauma is to be investigators. So taking a good history, it's very important from the patient regarding the mechanism of trauma, or if it's a burn, a chemical burn, and know the whole history to understand what was the impact and the force with from the trauma. I'm going to start with some basic stuff, like a corneal foreign body, and to make it a little bit easy in the beginning. A corneal foreign body is an object either superficially adherent or embedded in the cornea of the eye. It could be either metal, glass, wood, plastic, or even sand. It's, as I mentioned just a few seconds earlier, the history of a foreign body is very important. It can be from a wind blow, it can be from a high velocity procedure, hammering, grinding, that's very common, I believe, and anything like DIY and gardening. Every time that you see a foreign body, just keep it in the back of your head. That might be a possibly intraocular foreign body. And if the foreign bodies, if they're not removed in a timely manner, they can cause prolonged pain and lead to complications such as infections and further scarring that can lead to further visual problems. Symptoms, typically unilateral, then foreign body sensation, irritation, pain, watering, blurred vision, especially if they're close to the visual axis, conjunctival injection, red eye, sensitivity to the light, and excessive blinking. So these are the main symptoms when we have a corneal foreign body. I repeat, history is very important. We always ask our patients if they were doing any activity. High velocity particles, they're a big risk of cloud penetration. If there is anything metallic, there might be the formation of a rust ring, which I'm going to talk a couple of things about it later on. If it's vegetative, there's a risk of a fungal infection. Always do a VA before removing a foreign body for medical legal reasons as well. And consider using topical anesthetic, because imagine the patient is going to be in discomfort, watering, photophobia. So if you use anesthetic drops, it's going to be much easier to take a good visual acuity. Check always the globe and the lids for signs of any penetration, and when there is any suspicion of a penetrating injury, carry out a dilated fundus examination. There's not always a need to do that, but when there's this suspicion, better carry one. Check the anterior chamber if there's any inflammation, and definitely the pupil is a very important part of any part of injury. Signs. You might have the classic foreign body adhering to the ocular surface. You can see fluorescent stains, the cornea around the foreign body, or you can see linear corneal scratches. That is suspicious to avert the lid and see if there are any other embedded foreign bodies that can cause this. You can see a corneal rustering. I believe most of you are familiar with that, following a foreign body. I would advise you, if it is away from the visual axis, there's not any actual need to remove the foreign body, the rustering. But if it's close or on the visual axis, it's best to try to remove it. If it's too deep, it's best to remove the foreign body, wait a few days until the rustering with a re-epithelialization, remove a little bit forward so you can remove it after. If you think that it's a bit too much, if it's on the visual axis, of course, refer it to the hospital. But if it's on the periphery of the cornea, this is something that you can easily deal with, and you don't have to actually remove the rustering. Another sign is you might have a ring of swelling of edema, and an infiltrate is if it's long-standing, that can create further problems, and there might be present a subconjunctival hemorrhage. So back to basics. What do you need? Topical anesthetic, tetracaine, proximethacine, fluorescein strips, some cotton buds applicators. I don't use them that much. Definitely some irrigation fluid with a plastic syringe. something to remove the foreign body. I would be, and when I started to be a registrar, I was in a pediatric hospital, so I didn't feel comfortable using needles in kids that move around. And we had this gadget, the Algebras, which is very good. This is how an Algebras looks like. It has it has a rotating action, and it has a very fine tip. And these tips are they're not sharp at all. They're very blunt, like a tiny small ball. And you can action them, and it swirls around. It's very good to remove the rust rings. But if you don't action the rotating power of the Algebras, you can just use it to remove the foreign body. It costs around like £100, but I don't remember how much the single-use tips might be. That's a very easy thing. If you don't use to take foreign bodies of the cornea in your practice, you take once every like 2-3 months. It's a very safe gadget to have. Or you can use a sterile 25-27 gauge needle placed onto a syringe, because it's easier to use your hands using a syringe rather than having only the needle on your hand, with the guidance of a slit lamp always. I prefer sometimes to bend the needle. As you take it from the wrapping, you can use the wrapping on a hard surface, and you can bend slightly the needle. So when you approach the patient to remove the foreign body, it's like more like a spoon. So there's less likely to be traumatic, and you feel a little bit safer not to approach the cornea with a very sharp object. Some basics, slit lamp examination, position your patient. Yourself needs to be comfortable, and the patient as well. Just the first approach, remind yourself to position the canthus, the lateral canthus on the line. So when you approach the eye, you're directly on the eye. Use diffuse illumination in the beginning and proper magnification. Try to position your hands firm onto the patient, onto the slit lamp or the patient's face, or anchor them, as I mentioned here. So you have a nice steady hand. Place a few drops of anesthetic drops before. Use a fluorescent strip when you want to see if there's any staining. And always try to document the negative sagittal sign, because you might be surprised, and I'm going to show you one example or two. And always have time or spare some time to inspect the lower and the upper lid by doing lid aversion, especially if you see like many linear scratches on the corneal surface. If the foreign body is superficial, irrigate the eye to moisten the cornea and attempt to remove the foreign body with a coat-tipped applicator. Or I should have written, you have these tiny spears. They're very good. That's another safe way. But these are surgical spears, very nice, easy to use instead of using needles. As I mentioned earlier, you can use an Algebras or a 25 or a 27 gauge needle. You approach the cornea from the side in a plane tangent to the cornea. This minimizes the chance of corneal perforation. And as I said, if you go on the side and you bend the needle a little bit, it's like a spoon, and you can easily move and remove the foreign body. After removing the foreign body, patients should be placed on a broad spectrum topical antibiotic. Chloramphenicol is the easiest to find, 4 times a day for 3 to 5 days, or until the cornea surface is re-epithelialized. But actually, there's not any evidence that supports the use of antibiotic drops in superficial corneal defects. Definitely, if there is an infiltrate, you should use an antibiotic. But if it's completely superficial, it's going to re-epithelialize in a day or two. So, but always use antibiotics. Cycloplegia to prevent pupil spasm, so that would be cyclopentolate. Twice a day for a couple of days, just for the initial day or two. That will relieve the pain from the patient. Lots of ocular lubricants or an eye ointment, a gel. You can use everything that's available in the market. I prefer to use something that uses, it's a little bit thicker, uses vitamin A as well. It's preservative-free. It's a little bit thicker, but it's very good and helps with re-epithelialization of the cornea. Consider sometimes to use a therapeutic Barda contact lens, short-term to reduce discomfort, and remember not to prescribe topical steroids that I believe that you know that already. If the foreign body is iron-based, it might have quickly rusted to the eye surface, in which case the rustling will need to be removed, especially if it's close to the visual axis. If the foreign body has penetrated below the surface, it's likely to form a scar, I'm afraid. Some superficial anterior stromal avascular scars, less than 100 microns, can be amenable to treatment with PTK, phototherapeutic keratotomy. This is a laser that we use for other myopic or hypermetropic ablations, but superficial scarring can be treated as well. So that's a nice tool to have sometimes, especially if the scar is on the visual axis. So it's a thing worth considering if you have a patient like that. Now I'm going to give you an example. This happened back in March 2020. There was a 25-year-old patient who actually was seen by his optician with a deep foreign body, and very wisely referred this patient in clinic. Not though as it should, because the patient was seen 2 days later after the registrar, and it was after hours, probably was very busy on calls. The registrar very wisely saw the foreign body and said, oh, that's a little bit too deep, and he left it for me the following day to have a look. So this patient came, vision was excellent, was 6'6", had a foreign body sensation. The registrar said, oh, it looks deep. Before I did anything, I did the Cornell OCT. I don't know if you can see it here highlighted. And as soon as I did the Cornell OCT, you see here that there's a breach on the decimate membrane, and that was good enough for me to say, oh, that is in. And actually, this one, you can see it a little bit better. This is the foreign body here, and this is how it was embedded. What I did in the beginning, I tried to remove once I removed the foreign body, there was flattening of the anterior chamber. As a first treatment, I tried to place a bandage contact lens because I believe that I would be lucky. I thought I would be lucky to reinform the anterior chamber, to close it with a bandage contact lens. 20 minutes later, I saw the patient, he was waiting outside. The anterior chamber remained flat, so it was still leaking. So we used some corneal glue, and we placed the bandage contact lens that stayed on at least like 2.5 months, I believe. And then eventually that was removed. And 2 years later, I saw the patient regularly, but I wanted to show you the OCT scan on the anterior segment OCT scan on his cornea, exactly where the previous foreign body was. It has healed very nice. There's not a big scarring. It was away from his visual axis, so the patient didn't have any problems with his vision. That was a very nice thing to see. And also, I had to check the patient frequently while he had the bandage contact lens in case there was any fungal infection. As I mentioned earlier, we have to be more careful when there's some organic material involved. Now I have another patient, another example. This is a recent one that this was back in the beginning of September. A 54-year-old patient had a corneal abrasion referred in clinic with a tree branch. So something went into his eye. He felt foreign body sensation for 2-3 days, and then he came to the hospital. And when he came, we didn't see any foreign body, and he was treated like an infection because it felt like an infiltrate there. I saw him like 2-3 weeks after, I saw him the end of September, and he came in the clinic at the beginning of September. I saw him 2-3 weeks after he was seen in clinic because they were wondering what's that. I did an anterior segment OCT, and you can see that the foreign body just managed not to breach the decimate. And if you see the level, this is exactly where the foreign body was. Again, luckily, his vision was not affected, so he was very lucky not to have any problems from this. And he told me he was going to be very careful of wearing goggles next time. Now I have another patient, another example. It's a 63-year-old patient. He was grinding metal, and some foreign body went in his eye. What happened is he went to A&E, and I have to say he was not very fortunate because the emergency department nurse saw him there, tried to remove the foreign body with a needle without a slit lamp. So if you see in this area here, this hazy area here, this is all scarred. So it created these big scars on the cornea. And that was, the other eye was amblyoptic. So it started to become a big problem because his vision was good, it was 6 to 7.5. And he ended up with a vision at 6.15 for like 2-3 months because that area had to re-epithelialize and heal well. I used a bandage contact lens for a few weeks and some steroid drops to prevent further scarring. It worked quite well. If you see, this is the pachymetry of the on your top right. This is the pachymetry on the map on his cornea. It seems fine, it looks fine, but if you see the epithelial mapping, that area here is very affected. You see this increase of the epithelium thickness, and this was causing him problems with his vision and lots of aberrations. But eventually, after a few months, he managed to regain his vision, but he has this linear scarring on the cornea from the attempt of removing the foreign body. Now, I have another patient who presented back in April 2022, 23-year-old chap who was working at the construction. He took his goggles off because he was wearing his goggles, but another colleague of his was doing something, and then there was some metal dust blown into his cornea, and he had multiple tiny dot particles on the cornea. We managed to remove most of them. Some of them were very deep, and also he had some scarring. This is a big scar, and that was actually on the center of his vision. There was lots of corneal edema and inflammation. Slowly it settled. I saw him in the beginning of October, so last week I did a corneal OCT scan, and I wanted to show you this, that was in the beginning when he came, I think 2-3 weeks after he came for the first time. You can see the scarring here on the cornea, and this is the same area that was affected. So the scar has slowly faded. So this superficial scarring can be a little bit forgiven sometimes, but it takes time for all the healing process. It's a little bit deep to consider to do any laser here, but sometimes the cornea can amaze you with how clear or with the healing capabilities it has. Now I'm going to talk about some general mechanisms of injury to the eye. I'm going to talk about the blunt injury to the eye that can cause by blunt objects. The modes of injury is direct blow by the blunt object or accidental blunt trauma. Now, I'm going to explain more or less what is the mechanism of action of an injury into the eye. We have direct impact that produces the maximum damage at the point of blow, or we might have the compression wave force or countercoup damage, where the force of the impact is transmitted through the fluid context in all directions and strikes the angle of an anterior chamber, pushes lens diaphragm posteriorly, and also strikes choroid and retina. We have reflected compression wave force, so the compressor wave reflects towards the posterior post to cause foveal damage. And we have rebound compression wave force, where the compressor wave rebounds back anteriorly, damaging the retina and choroid by forward pull, and lens iris diaphragm by forward thrust. That would be this is the mechanism of action. So you understand when there's an impact into the globe, how the forces can transmit and create damage in other areas of the eye. So it's not only direct to the point of impact, but also this is the mechanism of how other structures of the eye can be affected, or indirect force from the bony walls and the elastic context of the orbit when the globe suddenly strikes against these structures. Lesions. The lesions that can happen after an impact like that is extraocular ones to the eyelids, conjunctiva, lacrimal apparatus, optic nerve and orbit. We might have a closed globe injury to the intraocular structures, cornea and sclera, and globe rupture. Now I'm going to talk about, there are like 3-4 slides, what are the effects of the ocular injuries. So this is valid for all injuries, not specific ones, but we're going to talk about a little bit, but all injuries. So this is like a list of things that can happen in the various parts of the eye. So on the eyelids, we might have ecchymosis, that would be swelling, or hematoma, the classic black eye. And this is a patient of ours who was punched on the eye. Or you can have an abrasion, laceration or avulsion, traumatic ptosis, or emphysema, where there's air from the paranasal sinuses. The lacrimal gland can be affected with a dislocation of the lacrimal gland, laceration of the canalaculi. Now, I'm going to show you an image. If you have a good stomach, see it. If you don't, just turn your view somewhere else. This is a patient of ours who had a fall at her house, and she went on in a corner. And if you can see here, the whole lacrimal apparatus and all this is completely gone. She had reconstruction of that area. I didn't have the photograph because she did amazing. If the eye was not affected at all, this is all external what you see. And she had a very good reconstruction, I have to say. But I'm afraid I didn't find the photo to show it to you. Then the conjunctiva can be affected with subconjunctival hemorrhage, chemosis, and laceration. On the cornea, we can have corneal abrasions, as we mentioned, or we can have recurrent corneal erosion syndrome if there's like a fingernail trauma. We might have a partial or complete corneal laceration, blood staining on the cornea. I'll have one example later on, and deep stromal haze or corneal edema with decimate folds. The sclera can be affected. We can have partial thickness scleral wounds, rupture of the globe at limbus or behind the insertion of the muscles. In the anterior chamber, we can have hyphema, injury to the iris or the ciliary body vessels, or exudates, traumatic iridocyclitis. Now, the iris is very important. There is so much information that you can get from a trauma, not only from the iris. We can have traumatic miosis from irritation of the ciliary nerves. We can have traumatic mydriasis or iridoplegia in Greek, permanent and associated with traumatic cycloplegia. These are a couple of examples of patients with traumatic mydriasis. We can have rupture of the pupillary margin or a radiating tear in the iris stroma. We can have iridodialysis, which is a detachment of the iris from its root, like a classic D-shaped pupil. We can have anti-reflection of iris when the internal part of the iris is going outwards. We can have traumatic aniridia, where following the trauma, you can see the iris completely dislocated. You can have angular recession complicated with glaucoma, or inflammatory changes, traumatic iridocyclitis or iritis, post-traumatic iris atrophy. On the lens, the effects of the ocular on the lens of a trauma, you can have something that we call a Vossius ring. This is a circular ring of pigment in the anterior capsule. Or when you have a traumatic cataract, a concussion cataract, we have this classic rosette cataract. This is the mechanical effect of the injury to the lens fibers. Or we might have a subluxation of the lens, where the lens is a little bit displaced, or complete dislocation of the lens in the anterior chamber or posteriorly. Effects, again, of the ocular injuries on the vitreous, we can have liquefaction of pigmentary opacities, classic vitreous detachment or a vitreous hemorrhage, or vitreous herniation in the anterior chamber when we have, as I said, bigger injuries like subluxation or dislocation of the lens. Then the choroid can be involved with rupture of the choroid, choroidal hemorrhage, choroidal detachment, and traumatic choroiditis. Now the retina, which is another important part. We might have something that we call commotio retina or Berlin's edema. I'm going to explain a little bit more later on. We can have retinal hemorrhages. We can have retinal tears, more common patients with myopic eyes or myopic or retinal degenerations. We might have a traumatic proliferative retinopathy, especially when the vitreous is involved. There might be traction. We can have retinal detachments or concussion changes at the macula. These concussion changes at the macula, I'm going to show you an example. This is courtesy of a case of Mr. Kashani. This is a 10-year-old boy, post-football injury. First, he developed something that we call commotio retina. which is a swelling of the retina. This is due to the mechanism of action that we described a little bit earlier. It's called Berlin edema as definition. Following the swelling of the fovea, there is some pigmentary degeneration that eventually develops to atrophy, or there is the possibility to develop macular cysts that they rupture, and the patient can develop a lamellar or full thickness macular hole. I had a case, but unfortunately I don't have any photographs, of a boy who was wearing his jacket, and there's this rubber band, and he pulled it and went into his eye. And unfortunately, the child had an ephema, so that's blood in the anterior chamber. When that settled, we found out that he developed eventually, after like a month or so, lamellar macular hole. Now, this is a case of a 27-year-old patient who came following assault in clinic with very poor vision. And one of my registrars had a look, and they asked me for my opinion. And I said, it's a little bit awkward that he developed these hemorrhages just on the region of the fovea. It looks, how come not in the retinal periphery? And by looking at the photographs a little bit better, I checked around these lesions in the nasal side of the retina, and then on black and white. We took some. Then I checked the photographs of the other eye, and if you see now the other eye, I don't know if you can see or if it's visible, these lines over here coming from the optic nerve. They are a little bit visible as well here, if you can see them. So these are called angioid streaks. As soon as I saw the photographs, I asked my registrar, can you ask the patient if he has ever heard of something like pseudoxanthoma elasticum or something like that, or something similar? And my registrar, the patient was in the other room, came back, and he said that he has been investigated as a child, and he had something that we call pseudoxanthoma elasticum. This is a condition where there is lots of elasticity in the connective tissue, and this is a typical finding of angioid streaks. And these patients are very prone to have an ocular injury following a trauma, and their vision can be affected because they can have retinal bleedings either way through the Brooks membrane. This is the OCT scan on presentation that was in November 2021. You can see the foveal hemorrhages and the OCT scan, and that was a few months later. All the retinal hemorrhages have been resolved, and there is like some scarring tissue. I'm afraid that his vision was greatly impaired. The other eye is 6.6. This one is like 660. And unfortunately, there was not any way to be able to salvage any of his vision. I'll continue with the effects of ocular injuries. And now we're going to the orbital injuries associated with fracture of the orbital walls, the classic blowout trauma. We can have orbital hemorrhage, and that causes sudden proptosis, that with the eye goes out. The appearance is that. Or we can have ethmoidal sinus rupture when we have orbital emphysema, when there is lots of air in the orbit. Or we can have a globe rupture from indirect rupture due to the compressor force, or due to the impact where we have momentary rise in the pressure, and we have a globe rupture mainly in the weakest point, which is the superior nasal limbus. So as ophthalmologists, when we have a case like that, we always check the eye, but this is the first place where you try to look if there is any globe rupture from an impact. Also, you might have prolapse of uveal tissue, vitreous, intraocular hemorrhages, and dislocation of lens, and of course the IOP would be low. Now I'm going to talk about a condition that you might happen to see following a trauma in your practice. It can be a big one or a small one. It's characterized by blood in the anterior chamber, and the signs and symptoms: blurred vision, pain. There might be blood or a clot in the anterior chamber, and definitely a history of trauma. As for classification, it can be microscopic, we call it microhyphema, or it can have different grades. The grade 1, 2, and 3 involve 1/3 of the anterior chamber volume, less than half, more than half, or we can have a grade 4, a total 8-ball hyphema. It's very important to bear in mind that when you have a hyphema, that it can rebleed, especially when you, after the first 3 to 5 days, when you feel that it's settling, it actually forms a clot. And it's possible that this clot is displaced, and then you have a new rebleed. So that is the main cause of a rebleed. The grade 1s can rebleed around 25%, and the grade 3s around 75% will rebleed. And they're going to be raised in IOP. And another consequence that can happen if it is prolonged is called corneal blood staining. And this is when there are particles of the blood, the hemosiderin, penetrates the corneal stroma, and it creates like a deposit. Treatment: bed rest and head elevation. Otherwise, if the patient is completely flat, the blood is going to disperse all around, so it's going to be a little bit difficult to resolve. And also, there is a bigger possibility for the patient to have a rebleed. Long-acting cycloplegic agents like cyclopentolate or atropine, steroid drops, dexamethasone or predforte, prednisone 1%, minor analgesic for the pain, and check for the pressure, because sometimes the pressure can be high. The follow-up of this patient, close follow-up, especially for patients with high risk of rebleed between the 3rd and 5th day. Refrain from any vigorous activity for a couple of weeks. Follow up within 2 and 4 weeks to monitor and document any improvement. Now, when things don't go the right way, when it's indicated to do any surgical treatment, when the hyphema and the pressure is more than 50, more than 5 days, that's to avoid optic nerve damage. When the hyphema is initially total, but it does not resolve below 50% within a week, with pressure around more than 15, and that is to prevent, as I just mentioned earlier, corneal blood staining, or the hyphema that remains completely unresolved for 9 to 10 days. I think that you can manage in your practice if you see like microhyphema, and definitely imagine that you would refer a patient with a hyphema more than 1 or 2 millimeters. But microhyphema you can see from minor injuries that can be easily managed in the community. This is a similar case. So from a blunt trauma, you might not see blood in the anterior chamber, but you might have something that we call traumatic iritis or iridocyclitis, to stick with the Greek language. The traumatic iritis is typically caused by the blunt injury that affects both the iris and the ciliary body. Traumatic iritis accounts for 20% of iritis, more or less. The trauma to the globe, to the eye, causes formation of these necrotic products. And these necrotic products, they stimulate this inflammatory reaction, and they increase the permeability of the blood vessels, that they allow inflammatory cells and inflammatory mediators, and sometimes blood contents to enter the eye tissue and eye media. It's typically unilateral. You can see lots of inflammation or flare in the anterior chamber. The vision will be decreased with some conjunctival injection and change in the pressure. Now the pressure can be high or can be low. Can be increased due to the inflammatory process because there's damage to the trabecular meshwork, or it can be decreased due to the damage of the ciliary body to produce aqueous humor. You might have meiosis as a reflex of photophobia, or mydriasis due to iris sphincter tears. The inflammation in the iris can cause synechiae that can be a problem in the future, and also we can have the formation of secondary glaucoma. Now, how the treatment and follow-up. Treatment is the same as hyphema, cycloplegics to dilate the pupil and prevent synechiae to the lens, steroids, dexamethasone or predforte, and if the pressure is high, we can use topical beta blockers. Follow-up of these patients need to be frequent in the first days, within 5 to 7 days of the initial traumatic event. When the iritis is resolved, the cycloplegics can be stopped and the steroids can be slowly tapered and discontinued. Follow-up should be occur in around a month, and gonioscopy should be performed at that stage to rule out any angular recession at that visit. You might now change the subject to like a subconjunctival hemorrhage. You might see that for other reasons, might be a small trauma, or some patient might rub the eye. Just ask your patient if they are on anticoagulants. It's very important, and ask the patient to see their GP for blood pressure monitoring and blood, especially if they recur. But that's only for small subconjunctival hemorrhages, not for big traumas, because that has to be investigated in a hospital setting. But if you see something spontaneous or the patient refers rubbing their eye, it's something that they don't need to worry too much about. Now, let's talk about ruptured globe. This is 3 times more common in males than females. The common causes are assault, domestic and occupational accidents. The extent of damage is determined by the energy caused by the flying foreign bodies. The risk factors include delay in primary repair, a ruptured lens capsule, and a dirty wound. This is a photograph of a patient of ours who had a ruptured globe. He fell and his eye fell on a corner, and unfortunately we have to remove the eye. Signs and symptoms: significantly decreased vision, shallow and flat anterior chamber. The pupil, as mentioned earlier, altered inside, or the position of the pupil needs to be documented. We might have visible tracks to the lens or vitreous tracing the line of passage in the foreign body. We might have marked conjunctival swelling, subconjunctival hemorrhage, or we might have a total hyphema with low pressure, and definitely a positive Seidel's test. Seidel's test, I believe most of you know, it's just when we put some fluorescein, and if we actually see some fluid coming from any part of the sclera or the cornea. Treatment: take a good history. Have an idea what caused the trauma. Blunt trauma, penetrating or perforating mechanism. Avoid to apply any pressure. If you have a shield, just put a shield on and avoid any straining. Definitely, you would refer to the hospital. If you saw something like that, you could ask the patient what happened and just put a shield and don't apply any pressure, and send the patient to the hospital. The arrangements for us as ophthalmologists would be to arrange an immediate surgical repair to prevent the risk of sympathetic ophthalmia. Sympathetic ophthalmia, it's a granulomatous uveitis that happens following the trauma to the other eye. So it's best to make sure that everything is done to prevent this. It's pretty rare, but prevent this from possibly happening. Tell the patient to be nil by mouth, cover with antibiotics and tetanus. Imaging, it's best to use a CT scan to detect a metallic foreign body, but definitely if there's a suspicion of a metallic foreign body, MRI is contraindicated because it can cause further problems. Finally, in talking about orbital fractures, we have the mechanism of action is the one that we described before, but we have breaks of the facial bones surrounding the orbit, 7 bones. We can have orbital floor fractures, medial wall fractures, lateral wall fractures, and superior wall fractures. I'm not going to go into details because when you see a patient like that, you're going to refer the patient eventually to the hospital. The most important thing is to check if there's any double vision in order to make sure that the muscles are not involved. What actually happens is that the bony defect is filled by soft tissue and fat from the orbit, and the extraocular muscles can be involved and trapped, and then we might have direct muscle damage that can happen. So that's why they need to be treated. It's not only that the patient cannot move their eye, they can have long-term sequela if it's not treated. Always try to check the cranial nerves to make sure that the optic nerve is not involved. And sometimes it might be very hard if you have a patient with a possible orbital fracture because it might be too much swelling, so you cannot assess the eye. Bear in mind also the max fax, if the eye is not involved, the time of the surgery to correct this is usually 7 to 10 days after the trauma in order to reduce the swelling that there is already there if the globe is not involved. Finally, I'm going to talk about the chemical injuries of the conjunctiva and sclera. The two agents involved are alkali or acids. They're both can cause blinding conditions. The alkali are lipophilic, and they penetrate the issues more rapidly than acids, so they can do more damage. This one I wanted to tell you. So they penetrate the corneal stroma and destroy the proteoglycan ground substance and the collagen bundles. And these damaged tissues then secrete proteolytic enzymes, would lead to further damage. So this is like a chain reaction when you have alkali. That's why they're more, let's say, they can cause more damage. Acids are generally less harmful than alkali, though. They can cause damage by denaturating and precipitating proteins in the tissues they contact. So they create like a barrier. That's why they're less harmful, but they're pretty harmful as well. The exception to that is the hydrofluoric acid, where they rapidly penetrates the thickness of the cornea and causes significant anterior segment destruction. These are the major alkaline acids that we find commonly around. Bear in mind, you see the alkalides plaster. Many times you might have like a patient coming, especially builders, when they have to do with plaster and cement. So we'll have to be a little bit careful on how to deal with these patients. Always take a good history, toxicity of the chemical, how long was the chemical in contact with the eye, when the injury occurred, whether the eyes were rinsed on the site and for how long, and what was the mechanism of injury, whether it was under pressure or if the patient was wearing eye protection, also for medical reasons. Physical examination. I know this is more hospital related. Must check the pH. The eye must be irrigated and bring the pH to an appropriate range between 7 and 7.2. Wait at least 5 minutes after irrigation before checking the pH. Many times when you have like a similar injury, they come from A&E. Oh, we have the pH is not good, so we have to see the patient. And we ask, when did you do the pH? Oh, just after irrigating. So you have to wait until to check the pH. Check always the palpebral fissures in the fornices during the initial examination in case there are some particles, as mentioned, plaster or cement. We have two classifications regarding the chemical injuries that they are very important to have an idea of the prognosis, what to expect. Definitely, you all know that it has to do with the limbal stem cells, which it is the area around the cornea that is responsible for the recreation, let's say, of the epithelialization of the cornea following an injury. These two classifications, they are based about how much is the limbal ischemia and the conjunctival status. And it's very good to have an idea what to expect as a prognosis from a chemical injury. The management, we start, as mentioned earlier, with early irrigation. It's critical in limiting the duration of the chemical exposure. The goal of irrigation is to remove the affected substance and restore the physiologic pH. It may be necessary to irrigate as much as 20 liters to achieve this, and to optimize patient comfort and ensure effective delivery of the irrigating solution is topical anesthetic is generally administrated and use eyelid speculum or a Morgan lens. We have that at the Conquest, I believe. I don't think they have it here in Eastbourne. This is a special lens that you place onto the eye, and then you irrigate directly the eye with this. This is very useful. I've never used it myself, but I remember a couple of times they told me that used it in the emergency department. It was very useful for them. The metal clip can be a little bit traumatic, especially if you have a patient that already had a chemical injury. Placing a metal clip is not the best thing, even if you use lots of anesthetic drops, because at that time, even the anesthetic drops don't work very well. Definitely, as I mentioned earlier, refer to ophthalmology, cyclopentolate drops, dilating drops, and chloramphenicol, and close the eye and send the patient to the hospital if you have the ability to use these. Long-term complications, it's scarring of the cornea, secondary glaucoma, dry eye, and damage to the lids and palpebral conjunctiva. This is just a classic example. The eye looks white, but you can see extensive damage to the cornea from the ischemia. That was it. I believe I finished within time, I believe.
Thank you very much, Mr. Ioannidis. That was excellent. That was
too much information, but
no, really
I hope our audience like that. We'll find out.
So we've got a few questions. Somebody did put their hand up during the talk, but I don't like to interrupt talk and it's in flow. So whoever put their hand up, if you want to type your question into the box, and I will definitely ask the question. So if you're ready, Mr. Ioannidis, so how often do you replace the bandaged contact lens?
Well, depends on the condition. So if you tell me about an abrasion, the contact lens can stay 1 or 2 weeks depending on what is the expectation. If I have to use the contact lens long term, 4 weeks. That's the longest I would use a contact lens. But in these cases that I use a contact lens, definitely would be under antibiotic cover. So preservative free, usually chloramphenicol or levofloxacin, whatever I have preservative free. But I repeat, depending on the condition. This patient who had a bandaged contact lens with corneal glue, so he had the corneal glue and I replaced the contact lens 2 or 3 times, I remember, because one time I had to remove it to assess and then I had to put another one. But generally, no longer than 4 weeks. Maximum would be 4 weeks under antibiotic cover.
Or you'll send them to me in the contact lens clinic to replace it for you every 4 weeks.
Of course, of course.
Was that linear scarring suitable for laser?
It depends on the depth. It depends on the depth. If it's deep enough, then the laser will not be able to reach that area. So that's why I showed you one that was a little bit deep and another one that managed more or less not to affect the patient's vision, because it's all about not what we see as ophthalmologists or as healthcare professionals like you guys. It's because you might see a scar and the patient might say, okay, I don't have any problems with the vision, so why bother? If it's deep and it affects the vision, it's going to be a little bit difficult. If it's superficial, then laser can help a little bit in these cases. That's the only criteria, how deep it is.
Thank you. Is it possible to detect angle recession without gonioscopy?
You can suspect it in patients who have high IOP following a blunt trauma or traumatic iridocyclitis that I mentioned, or patients after having traumatic hyphema or traumatic iridocyclitis. It goes with the pressure, I think. That's why I mentioned earlier, do a gonioscopy when you have traumatic iridocyclitis when you can, and when there is a hyphema, you have to wait a little bit as well. That settles to check. Always do gonioscopy. So it's difficult for me to tell you not to do it because I do it. It's second nature.
I think it's difficult.
But if there are problems with if the pressure keeps on is not controlled, that might be there's definitely some damage.
I think it's difficult. In practice, we won't do gonioscopy in community as they do in the hospital. So I can see why.
But it's a good skill to have, I believe, gonioscopy. But yes, I know. It's tough, but definitely if you have problems with the pressure, so a simple criteria would be if you have a mild traumatic iridocyclitis. Okay, we're talking a mild. So you saw a patient, pupil response is good, some cells in the anterior chamber like +1, you give him some cycloplegic drops, you give him some steroid drops, you see him the week after, all good. You check the pressure is high. Not very high. The other eye is 15, you have like a 22, 23. Yeah. You say, okay, come next week, we'll see, we'll let the eye to settle, don't take any steroid drops in case there's a steroid responder. You bring the patient next week, again, 22, 23. The other eye stays at 10. Something must have happened. This, okay, might not be the indication to tell, oh, there's a problem, angular recession, but there might be actually a problem. So you can have the suspicion that you cannot be sure unless you do it.
Yeah, thank you very much. What is the best route of referral for a symptomatic off visual axis foreign body that can't be treated in practice?
That can't be treated.
Can't be treated in practice. What's the best route of referral? Emergency, sort of?
That would be, depends on the hours. If it's in with working hours in Est, we will take the referral and then see the patient accordingly. If not the same day, the following day. If it's after hours, I'm afraid it goes to A&E, and the A&E doctors see them first. They try to attempt to remove the foreign body. If they can't, then they contact us. Mm-hmm. So even if it's off visualitis, I've seen some foreign bodies that we have to deal with dealing with patients that most of the times they're not aware of the situation. I've seen some other people with a minor problem come to the hospital. I've seen other ones that they have a foreign body 3-4 days. It has created a big infiltrate. Now you deal with an infection. So I would suggest that if it's within working hours, you contact through the emergency route for our hospital. After hours, definitely A&E will try to deal with this patient first. As an ophthalmologist, I prefer to remove this the first day. I don't want to deal with the problems that they can happen after. So my way of treating these things is I want to see the problem before it gets bigger.
Yeah.
I don't know if I know it doesn't answer completely your question. I'm sorry for this. Because the hospital, I'm afraid, works in a different thing. I would love to see all patients that are referred the same day, but unfortunately, that's not the case. Yeah. And that happened as well. If that patient that had this thorn that penetrated the decimate, he was seen in clinic 2 days after he was referred. And if you ask me, I don't like that. That's not ideal.
So leading on to the next question, what situations would you recommend a high street optician can remove a foreign body, or should all be sent to the hospital?
Foreign bodies, which are not on them. So superficial foreign bodies, even if they are on the visual axis, you can just remove them. They can reepithelialize. If you're an independent prescriber, you can prescribe chloramphenicol, which I mentioned earlier. It's not essential. If it's too superficial, you can prescribe or give lubricating drops and a gel to use lots of times within the day, and that will heal. So very superficial ones, you can remove them. Mm-hmm. And if there are deeper ones in the visual axis, you can refer them to the hospital. Peripheral ones, you can definitely remove them. It's not rocket science. If you're not confident, I imagine, okay, that's fine. We're talking about confidence and not about dealing with a problem. Having an algebras that I mentioned might be a bit difficult to use from the point of view that you have to, I don't know how it's going to be possible. It costs like £100, and then I don't know how much the tip costs, and you have to explain to the patient, I'm doing a procedure to you. They have to pay. It's not something that you just have in your drawer like 100 of these and you use just free. So foreign bodies that they are away from the visual axis, they're not very deep. I think that any optometrist has the skills to deal with that. I usually advise, if you don't have an algebras, you can bend the needle, and you can imagine even if you press the needle on a hard surface on the piece of paper, on the wrapping, it bends that nice, and it's like literally like a spoon. So you go close to the cornea, you go like this, and you remove the foreign body quite easily.
Thank you. I should have asked you to stop sharing your screen so we could.
Oh, sorry. So
the next question, and I'd like your full honest answer to this. So this is from Mr. Sharam Kashani. Great talk, Mr. P. Can you answer that one?
No, I'm looking forward to his. I'm sure he has more interesting things than me to say.
I'm hoping he's learned a lot from tonight's talk, but
don't worry, I'll update him tomorrow. During his clinic, I'm going to have it on his screen.
But that was the last of the questions. So thank you, everybody who asked a question. And thank you all for watching tonight's talk. I'd like to thank Mr. Ioannidis, it doesn't get paid for doing this, and he's put a lot of work into doing the presentation tonight. The lecture tonight has been recorded, and I will put up on the YouTube channel in a couple of weeks' time when I can find the time to do it. I will aim to send the CPD certificates out this weekend, but there's over 100 people registered, so there's going to be quite a few certificates for me to get sent out. But I'd like to thank you all again for joining us tonight, and thank you, Mr. Ioannidis, from us here for doing this.
Thank you, Ian, for the invitation.
Oh, you're welcome. And look forward to seeing you all again on the next talk. And I think it's Mr. Sharam Kashani's turn to do the next talk. I'm waiting to hear from him what the title will be and the subject. So I'm looking forward to that one. And let's hope we can get as many people to watch that one as have watched this one. So
I will join.
Stay safe, and thank you very much for watching. And we'll see you soon. Thank you.
Bye, all.